I think that's one of the principal aim that we have for the meeting this year here is how to combine medical surgical treatment to improve active function for patients with central nervous system damage. Is exactly our reflection in Garches and in France, and how can we combine all this treatment and not only botulinum toxin, physiotherapy, surgery, neurosurgery, that stuff. And we wanted to propose to you our experience and maybe to have after a discussion, not maybe today, but for the future, how can we have this reflection all together with surgeons and physicians for the treatment for these patients. So that's true. The extension and generalization of botulinum toxin injection and the new approach of multidisciplinary intensive and repetitive rehabilitation have considerably modified the practices of the treatments of the motility disorders and consequently of the neuro-orthopedic treatments. And as you know, a neurological lesion does not only lead to muscular hyperactivity, but there is some change in the muscle viscosity, and obviously that leads to hypoextensibility and contracture. And botulinum toxin is not effective on these intrinsic changes of the muscles. And neuro-orthopedics that treats contracture, joint stiffness, etc., by tendon lengthening or transfer seems to be a complementary solution against joint deformation and consequently for the function. It allows a redistribution of the injections in other muscle, and it promotes the interest of the toxin for the preoperative evaluation of the surgery and in the post-operative complement. I am going to present very, very quickly the techniques we use in Garches, but everyone knows now at this time in the meeting, so I'm going to go very, very quickly, but it's just to show what kind of technique we use. Obviously, we perform the tendon lengthening. We have said a lot this morning about this kind of treatment, but maybe the tendon lengthening has an impact on the spasticity by reducing maybe the hypertonia of an hypoextensible and hypertonic muscle by modifying the threshold of the neuromuscular spindle, maybe. And so if you associate this surgery with, for example, a neurotomy, you can have an impact on the spasticity, on the muscle hyperactivity after the surgery. So, as we have said this morning, we can do simple tenotomy, we can practice large needle tenotomy, and it's a little bit provocative, but this treatment of tenotomy can be practiced for this kind of deformation when there is a real contracture of the muscle during a botulinum toxin session injection. So you can do maybe in the future this treatment both in the same session. So it's a combination of the two treatments. We perform either intramuscular tenotomy for again to about 15 to 20 millimeters. We can practice obviously the Z-tenotomy, which for each one, everyone knows here that there is some specific indication. And there is obviously, and we have, Antoine Geoffroy has presented this morning, the Page-Scaglietti procedure that can be positioned between the intramuscular and the Z elongation in the functional approach for the tendon lengthenings for patients with central neurologic system damage. Obviously, there is tendon transfer, but as you know, for central neurologic patients, we can use this procedure for modification without change of the biomechanical function, because that's very difficult for this patient if you change the biomedical function of the muscle for this kind of patient, because it requires plasticity of the motor control and consequently pronounced rehabilitation. So we practice active tendinous transfer with pattern transfer. We saw that this morning. and passive transfer, obviously, tenodesis. And the active tendinous transfer use very, very often the synkinetic contraction of the desired action. Obviously, that is really, really important for us, and we forgot it very, very often in our department. It's the joint stability, the joint stabilization. After botulinum toxin injection, we don't have very, very often this idea, okay, we are going to gain a little bit for the motion, but is the stabilization will be improved or not? And with surgeons, we can practice this kind of treatment, associated bone and joint gestures. Arthrodesis with limited indication when you have to perform it, that's very, very interesting. And sometimes osteotomy. And you can join to all this kind of treatment, obviously, the surgical treatments for spasticity and mainly for this kind of patient, neurotomy. Neurotomy that treats focal spasticity without retraction. That's why you have sometimes to practice some motor nerve block pre-operatively to eliminate contracture. Obviously, there is dresotomy, but very competitive aspect with the intrathecal baclofen, and Jamel Ben-Smaili is going to speak about this. But you can now have the idea to use intrathecal baclofen, for example, and tendon lengthening and botulinum toxin for the same patient. And we have to have this reflection about how we organize all this treatment. Is there any guidelines? And I'm going to prepare the a wonderful talk of Thierry Deltombe for tomorrow morning. And when you try to compare the principle and the means of neuro-orthopedics focal treatment, and you want to compare medical and surgical, they are quite the same. Equilibrate the agonist-antagonist balance. How? Relaxing the agonist, and with the medical approach, you can have an action of spasticity or contracture, with botulinum toxin and intrathecal baclofen, action of the nerve, and surgically with partial neurotomy, for example, dresotomy, and the action on the contracture. With the same aim of equilibrate the agonist-antagonist balance, you have to strengthen the antagonist. How? With physiotherapy, self-guided rehabilitation in the medical approach. And you can, with a surgical approach, use transfers or tenodesis. And what is for us very, very important, you have to ensure the mobility and the joint stability. And this can be done with functional electric stimulation, self-guided rehabilitation, as it was presented by Céline, or physiotherapy. But you can practice surgically arthrolysis, asho removal, arthroplasty, arthrodesis, osteotomy. So we have a lot of means to improve active function, and we have to work all together just to find a way to find a good treatment for the good patients. Obviously, this needs an engagement with the patient and or the caregivers to determine the first goal. And then the hierarchy of the other goal, you are going to see that. As surgery perform irreversible gestures, the pre-operative evaluation must be draconian, and sometimes we use motor nerve block in our practice. The type of elongation depends on the risk of recurrence, and the condition of osteogonist is the real problem we have. Because when there is a contracture, to find how will be the antagonist after the lengthening is sometimes really, really difficult to assess. And the hierarchy of the correction, if there is a multiple deformation, in Garches, Philippe de Normandie said, well, if the goal is hygienic, you can try to do all this deformation in one surgical look. But if there is a functional aim, I think you have to go step by step. And so multiple surgical looks. And what is really, really important, it's the management of the post-operative autonomy for this patient, obviously. The immobilization time, with or without body weight support. Do we have to inject botulinum toxin before casting to be sure that the patient will be comfortable in his cast? And all that stuff costs a lot of time. Sorry, Alberto, but it won't be possible in 26 days for us. And obviously, we had bad results. And the bad results we have, it's overcorrection. Mainly, it's the under-evaluation of the antagonist. Sorry for the orange color of these slides. To assess the dystonia, sometimes a failure of sutures. Sometimes there's a recurrence of the deformity, and very often it's because our transfer is insufficient, and tenodesis is always here, sometimes insufficient. And we have to assess, as physicians, the associated disability, the proximal muscle weakness, cerebellar syndrome, and all that stuff. So, and for this kind of patients that are very, very fragile, they obviously can have the classical surgical complication as sepsis, delayed bone healing, and all that. So I can show you, if you want, just here, one of our bad results. We have underestimated after the tendon lengthening of the triceps, the overactivity of the tibialis anterior that was totally masked before the surgery. So now, just to finish, I want to show you two examples to illustrate a little bit my talk. You can see here a patient with a young patient with left hemiplegia at the beginning of the care, with spasticity, retraction, loss of command, and after several months of botulinum toxin injection, physiotherapy, and neuro-orthopedic surgery with lengthening transferred, you can see here, I hope so, yes, oh. That it's a little bit better, without crutch, walking maybe with a recurvatum of the knee on the left, here. And that's why, continuing our process of physiotherapy, botulinum toxin injection, we have had an orthosis. Oh, yes, I think it will come. And nowadays, she's walking like this. And we think that maybe it's because we have put all together this treatment that we can have a real improvement of the active function. So it's a global multidisciplinary approach that needs evidence, time, and several months. And to finish here, you can have here a patient that you know is synkinetic contractions of the tibialis anterior, and with the half transfer of the tibialis anterior, the tendon lengthening of the triceps, the neurotomy of the soleus branch, and the injection of botulinum toxin in the fibularis longus and now in the rectus femoris permits to this patient to walk like this. So for us, it's an improvement of the active function. And so at the beginning, I thought that when the patient with the central nervous system damage arrived in our department, he benefited from physiotherapy, physical activity, after that botulinum toxin injection, and at the end, when there were some contractures, he benefited from neuro-orthopedic surgery, and that was the end of the story. And nowadays, we think that we have to change a little bit on our mind, and a patient now have to benefit for a long time from all this treatment. But when he needs neuro-orthopedic surgery, he can continue to benefit from botulinum toxin injection because, for example, there is some new muscles with overactivity that were masked by the deformation, or the new goal for the patient, and he wants to run because at the beginning he was only walking. And we have to deal, I think, to think about new guidelines for this kind of treatment and to be sure that we are going to go in the same way. I think that's very, very important. Antoine proposed the study of the Page-Scaglietti procedure at the beginning of the morning. And you can see here that there were 55 cases. There is 34 cases who, for this patient, we continue to inject botulinum toxin after the surgery. Increased dose in muscles already injected or in new muscles from which the overactivity was unmasked by the correction of the deformation, or because there is new goals. because a bedridden patient wants to be seated, a seated patient wants to stand, a standing patient wants to walk, and a walking patient wants to run. So that I think that's a discussion that we have to have after this Congress, just to find altogether a strategy for this kind of patient. Thank you so much.